imagine this. You are in the trauma bay. Your burn patient is breathing. Their initial chest x-ray is perfectly clear.
Yeah, and you look up at the monitor, and their blood oxygen saturation is sitting beautifully at 100%.
Right, exactly. Everything looks stable. And yet, this patient is quietly suffocating on a cellular level, and you are about to miss it.
That's a terrifying scenario.
It really is. Welcome to this deep dive. We are jumping straight in today because, well, this is a rapid-fire, high-yield revision session designed specifically for you.
Yeah, you are a resident preparing for board exams like the FRCS in plastic surgery, and our mission today is to cut through the noise.
Spot on. We are going to master the underlying pathophysiology and the clinical management of inhalation injury and carbon monoxide poisoning.
Exactly. We're looking at the clinical traps, the essential algorithms, and most importantly, the underlying mechanics you really need to know.
Right, because this is not about memorizing textbook lists.
No, not at all. It's about deeply understanding the why and the how so you can confidently navigate those complex, deteriorating clinical scenarios on exam day.
Absolutely. And before we start the clock on this revision session, just a very quick reminder, if you learned something valuable today that helps your prep, hit that follow button on the show and leave us a rating.
Yeah, it really helps.
And if you want to take your revision to the next level, get a premium subscription that unlocks our exclusive journal club and clinical cases deep dives.
Which are just absolute gold for your exam prep.
They really are. All right, no nonsense. Let's get right into it. We're going to run this in a strict question and explanation format, but instead of just firing facts back and forth, let's thread a single evolving clinical case through this entire deep dive.
I like it. Let's build a scenario.
Okay, let's unpack this. You're in the emergency department. You have a severe burn patient who has just been stabilized after being pulled from a house fire, and they're about to be transferred out to a specialized burns unit. So here's the first clinical friction point. Do we start prophylactic steroids or antibiotics right now to protect the airway? And who absolutely needs to clear this patient before they are loaded into the ambulance?
So the answer to the first part is a definitive no.
Okay.
Prophylactic steroids or antibiotics are not indicated. You just do not start them.
Because giving high-dose immunosuppressants to a patient who has just lost their primary skin barrier is, asking for a systemic infection, right?
Basic.
And prophylactic antibiotics just breed resistant bugs without actually preventing pneumonia.
Exactly.
Yeah.
The risks far outweigh any theoretical benefit there.
Okay.
And as for the second part of your question, an anesthetist must review the patient prior to any transfer to a burns unit.
That's our rule.
It is non-negotiable. You cannot put a potentially rapidly compromising airway into the back of an ambulance without an airway expert signing off.
Spot on. But let me push back on that initial assessment because this is the classic pitfall we open the show with.
Right, the clear x-ray.
Yeah. You look at their initial chest x-ray, and it is completely clear. You pull their initial arterial blood gas, the ABG, and the numbers look perfectly normal. Does that mean we can safely rule out inhalation injury?
Absolutely not. That is the exact examiners and real life, frankly, will set for you.
Oh, wow.
Yeah, inhalation injury is fundamentally a clinical diagnosis. Initial chest x-rays are going to be normal because the injury starts as a mucosal insult.
Oh, I see.
It takes time for alveolar infiltrates or pulmonary edema to physically show up on a radiograph.
So it's a false sense of security. You look at the paper says normal, but the patient's airway is quietly swelling.
Exactly.
What about carboxyhemoglobin levels on that blood gas? Surely that gives us a definitive answer to whether they inhaled smoke.
Well, they are useful, but they come with a massive caveat.
Which is?
Those carboxyhemoglobin levels might appear completely normal if the patient received oxygen during the transfer to the hospital.
Wait, really? Just from the ambulance ride?
Yeah, the high-flow oxygen therapy given by the paramedics masks the initial spike by driving the carbon monoxide off the hemoglobin before you even draw the blood.
That's wild.
You cannot rely solely on early labs or imaging.
Okay, so if the basic tests are lying to us, what is the gold standard? If we need to know for sure, how do we make the definitive diagnosis?
The most reliable, definitive method is fiber optic bronchoscopy.
Yeah.
You have to physically look at the internal anatomy of the airway.
And what exactly are we looking for when we pass that scope? Like, what are the physiological changes?
You're looking for 4 key characteristic findings.
Okay.
First, soot present below the vocal cords. Second, hyperemia, which is that angry red increased blood flow to the tissues.
Right.
Third is mucosal edema.
Yeah.
And finally, active ulceration of the airway lining. If you see those on bronchoscopy, you have your definitive diagnosis.
Perfect. So, before we even get to the point of passing a bronchoscope, we need a high index of clinical suspicion. Walk us through the history, the symptoms, and the clinical signs that should immediately scream inhalation injury to anyone assessing a trauma patient.
Sure, let's start with the history. The classic red flags are a history of inhaling hot gases or vapors from a fire, specifically a fire in an enclosed space,
Okay.
or a patient who was found unconscious. Those scenarios mean prolonged, inescapable exposure.
Right, that makes sense. What are the symptoms the patient might actually complain of, assuming they're conscious and talking to you?
They will likely have a hoarse or remarkably weak voice, a harsh, brassy-sounding cough, and general restlessness.
Restlessness.
Yeah, which is often an early sign of hypoxia. And, of course, shortness of breath.
Okay, and the objective signs. When you are examining them head to toe, what are you physically looking for?
You are looking for soot around the mouth and nose, singed facial and nasal hair, and deep burns to the face, neck, and upper body.
Basically the blast zone.
Exactly. Inside the airway, you might see carbonaceous sputum, or actual carbon deposits in the mouth and oropharynx. And then you have the late signs of critical airway compromise.
You sure?
A visibly swollen upper airway, stridor, dyspnoea, profound hypoxia, and eventually the crackles of pulmonary edema.
Man, here's where it gets really interesting. In the exam, they're going to want you to differentiate the injury anatomically.
Right.
Break this down for us into supraglottic and subglottic injuries. They sound similar, but the mechanism of damage is completely different, isn't it?
They are entirely different beasts. Let's start with a supraglottic injury, everything above the vocal cords. This is caused almost exclusively by direct thermal heat.
Right. The upper airway acts as a massive heat sink. It absorbs the thermal energy to protect the lungs. So supraglottic is a pure thermal burn.
Exactly. And the crucial takeaway for supraglottic burns is the ticking clock. Because it's a direct thermal burn, massive, rapid swelling is inevitable.
So you have to move fast.
You do. The airway must be secured early, usually via endotracheal intubation, before that swelling develops over the ensuing hours and completely obliterates your anatomical landmarks.
Wow.
If you wait to see if they get worse, you will lose the airway. The only good news here is that this specific thermal edema usually resolves spontaneously within 3 to 5 days.
Okay, so supraglottic is a direct heat burn characterized by rapid swelling. Now, what about subglottic? Everything below the vocal cords down deep into the lungs.
Subglottic injury is rarely caused by heat because the upper airway absorbed it all. Subglottic damage is caused by the products of combustion.
The chemicals.
Right. These act as direct toxic chemical irritants to the delicate lung parenchyma. It leads to severe bronchospasm, profound inflammation, and bronchoria.
Bronchoria.
Yeah, which is the massive overproduction of watery sputum as the lungs try to flush the irritants out.
Let's focus on the pathophysiology of the mucociliary elevator, because this is a high-yield concept for the boards. If the subglottic injury is a chemical burn, how does that affect clearance?
It destroys it.
Let me try an analogy. The mucociliary elevator is usually like an escalator constantly moving debris up and out of the lungs. But the toxic smoke essentially cuts the power to the escalator. It breaks down.
That is a perfect way to visualize it. Profound dysfunction of the mucociliary elevator is the hallmark of subglottic injury.
Okay.
The escalator stops working, but the body is still dumping massive amounts of inflammatory fluid and sloughing dead cells onto the bottom step. Because it's broken, all those excessive secretions pool deep in the lungs.
And a blocked airway means a collapsed airway.
Precisely. This pooling leads directly to atelectasis, the collapse of the alveoli adult respiratory distress syndrome, or ARDS, and inevitably secondary pneumonia.
Because that pooled fluid is a perfect breeding ground for bacteria.
Exactly.
Mechanically, what else is happening to the lung tissue during a subglottic injury?
Because of the collapse in the fluid, you get severe ventilation-perfusion mismatching. Blood is flowing to areas of the lung that are no longer receiving oxygen. You also see significantly decreased lung compliance. The lungs become stiff and fibrotic feeling, making them incredibly hard to inflate, and you get a massive increase in airway resistance.
So we have secured the swollen supraglottic airway, but now we are dealing with stiff, failing lungs full of toxic sludge. What is in our respiratory support arsenal to manage this subglottic failure?
Well, you start with humidified oxygen and intensive chest physiotherapy to try and manually move that sludge.
Okay.
You may need non-invasive ventilation with positive end expiratory pressure, or PEEP, to stent those collapsing airways open.
And if that doesn't work?
In severe cases, you must proceed to intubation and ventilation, specifically to perform bronchial lavage with dilute sodium bicarbonate to literally wash the chemical irritants out.
That sounds intense. And we also use a specific cocktail of nebulizers. Walk us through those and critically explain exactly why we use each one. Mechanics are everything here.
Right. You need to know 3 main nebulizers. First, heparin.
Heparin in the lungs.
Yeah, we use nebulized heparin to prevent cast formation in the airways. The chemical burn causes fibrin and cellular debris to clump together into solid casts that plug the bronchi. Heparin interrupts that coagulation cascade locally in the lung.
Oh, brilliant. Okay, second.
Second, acetylcysteine. This acts as a mucolytic. It chemically breaks the disulfide bonds in that thick, pooling mucus so it can be suctioned out.
Perfect. And the third?
And third, salbutamol, which is a straightforward bronchodilator used to counteract the intense reactive bronchospasm.
So what does this all mean for the cellular level? We've talked about the physical upper airway burns and the chemical irritants in the lungs.
Right.
But even if we perfectly secure the airway and clear the lungs, we have to tackle the systemic invisible killer inhaled from the fire. Let's talk about carbon monoxide, or CO, poisoning. Explain the mechanics of why CO is so deadly.
What's fascinating here is the terrifying mathematics of the molecule. Carbon monoxide has 250 times the affinity for deoxyhemoglobin as oxygen does. It outcompetes oxygen effortlessly.
It acts like a bully stealing every single seat on the life raft. Even if there's plenty of oxygen around, the oxygen can't get a seat on the hemoglobin to travel to the organs.
Exactly. The blood simply cannot carry oxygen. But it actually gets worse.
How so?
CO doesn't just stay in the bloodstream. It crosses into the tissues and binds directly to intracellular cytochrome proteins. This affects the mitochondria, essentially shutting down cellular respiration at the most fundamental level. The cells starve, even if blood is reaching them.
Oh, and this brings us back to the trap from the very beginning of the deep dive. Why are standard pulse oximeters in the trauma bay completely useless here?
Because standard pulse oximetry measures the percentage of hemoglobin that is bound to a molecule, but it cannot differentiate between oxyhemoglobin and carboxyhemoglobin.
Ah, of course.
A patient could be actively dying of cellular hypoxia, and the pulse oximeter will cheerfully read 100% saturation because it sees that the hemoglobin is fully occupied by the carbon monoxide. It is a highly dangerous trap.
So we pull the arterial blood gas. What does the ABG show us mechanically?
The ABG will reveal the true story. It will show elevated carboxyhemoglobin levels and, crucially, a marked metabolic acidosis.
Because of the starving cells.
Exactly. That acidosis is the byproduct of the cells resorting to anaerobic metabolism because their mitochondria have been shut down by the carbon monoxide.
Give us a quick cheat sheet on the CO percentage levels for the exam. What numbers are we looking for?
Okay, up to 10% carboxyhemoglobin can actually be considered normal if the patient is a heavy smoker or a truck driver exposed to exhaust.
Right.
At 15 to 20%, you see headache and confusion. Between 20 and 40%, the toxicity hits the central nervous system hard, causing hallucinations and ataxia.
And fatal levels.
Carbon monoxide levels of 60% are fatal.
How exactly do we treat it, and what is the math behind the treatment?
The treatment is 100% oxygen, delivered through a non-rebreathing face mask with a reservoir.
And if it's severe?
If the carboxyhemoglobin levels are greater than 25 to 30%, the patient requires immediate intubation and mechanical ventilation.
And why 100% oxygen? Explain the half-life shift, because this is brilliant pathophysiology.
The half-life of carbon monoxide in a patient breathing normal room air is approximately 250 minutes.
That's a long time.
It is. But if you flood their system with 100% oxygen, you use sheer competitive pressure to aggressively drive the CO off the hemoglobin. By doing that, you drop the half-life from 250 minutes down to approximately 40 minutes.
That is a massive physiological acceleration. But here's the critical clinical question. When do we stop the 100% oxygen? Do we just wait for the carboxyhemoglobin level on the blood gas to drop back to zero?
No, and this is a vital point for your exams. You must continue the 100% oxygen until the metabolic acidosis has completely cleared.
Wait, why? If the blood CO level is low, why are we still treating them like they are poison?
Because of those intracellular cytochrome proteins we mentioned earlier. The blood clears first.
Go ahead.
Yeah, but even after the blood hemoglobin is cleared, there is a later secondary release of carbon monoxide from the cytochrome system back into the blood. The clearing of the metabolic acidosis is your only true, reliable indicator that the intracellular toxicity, the actual mitochondrial poisoning, is resolving.
That makes perfect sense. If we connect this to the bigger picture, these patients are often in the ICU for a very long time. They have massive burns, they need repeated trips to the operating theater for grafting, and they are on a ventilator for weeks. Let's weigh in on the use of tracheostomies to manage the airway long term.
Well, there is no absolute universal consensus on tracheostomy use in burn patients.
Really?
Yeah, however, they are highly utilized and incredibly beneficial for this specific population, patients with large burns and severe inhalation injury who require prolonged mechanical ventilation.
What are the specific physiological benefits of a tracheostomy in this context?
The first major benefit is logistical access. It provides easy, direct access to the bronchopulmonary tree for the constant pulmonary toileting and lavage these patients need because of that subglottic pooling we discussed.
Right.
The second major benefit is that it significantly improves ventilator weaning.
Break that down for me. How does a hole in the neck improve weaning mechanically compared to a tube through the mouth?
It reduces dead space by 10 to 50% compared to an endotracheal tube. You are bypassing the entire mouth and throat.
That's a huge reduction.
It is. By shortening the tube, you are drastically decreasing airway resistance. That directly decreases the patient's work of breathing.
And they need less sedation too, right?
Exactly. Because a tracheostomy is much more comfortable than having a long tube taped to your face and gagging you, it significantly decreases sedation requirements. Less sedation means the patient can wake up and start initiating their own breaths sooner.
Those are compelling benefits. But I want the flip side. Let's talk about the nightmare complications. And don't just list them for me. Explain the mechanics. How exactly does a tracheostomy cause a tracheoesophageal fistula, a hole between the airway and the swallowing tube?
It comes down to pressure necrosis. The tracheostomy tube has an inflatable cuff to seal the airway.
Okay.
If that cuff is overinflated, it presses hard against the back wall of the trachea. Right behind that wall is the esophagus, which often has a rigid nasogastric feeding tube inside.
Oh man, so it's getting squeezed.
Precisely. The tracheal tissue gets sandwiched and crushed between the inflated balloon and the rigid feeding tube. The blood supply is cut off, the tissue dies, and a hole forms.
That is a brilliant visual for the exam. What are the other complications?
Bleeding or catastrophic erosion of the brachiocephalic vessels, which happens if the rigid tube pulsates aggressively against the blood vessels. You also risk accidental decannulation, the tube simply falling out. Long-term, you see swallowing dysfunction, tracheal ulceration with granulation tissue formation, and eventually tracheal stenosis, where the airway heals by scarring and narrowing.
Excellent. Now let's talk about the broader complications of mechanical ventilation. We have this severely damaged airway, and now we are dealing with stiff ARDS-affected lungs. What are the mechanical risks of pushing positive pressure air into a lung that feels like a brick wall?
The primary mechanical risks are barotrauma and pneumothorax. These result from the extremely high ventilatory pressures required just to overcome the poor lung compliance and the dramatically increased airway resistance.
So the pressure just plops the lung?
Essentially, yes. The lungs are stiff, you are forcefully pushing air in, and the delicate alveolar tissue simply tears, leaking air into the chest cavity.
So how do we push air into a stiff lung without blowing a hole in it? What is the exact strategy?
We must use strict lung protective ventilation strategies.
Let's list the exact parameters of that strategy and explain why we use them.
First, you utilize pressure-controlled ventilation rather than volume-controlled, so you never exceed a safe pressure limit.
Makes sense.
You set a high ventilation rate, but use very small tidal volumes to avoid overstretching the tissue. You employ inverse ratio ventilation, and you maintain a physiological PEEP of approximately 5 centimeters of water to keep the alveoli from collapsing completely at the end of a breath.
Stop on inverse ratio ventilation for a second. Mechanically, how does spending more time in inspiration actually protect a stiff lung?
Normally, we spend more time exhaling than inhaling. In inverse ratio, we flip that.
Okay.
We deliver the breath very slowly over a longer inspiratory time. This slow, sustained pressure allows the air to gently navigate the blocked, resistant airways and gradually pop open collapsed alveoli without requiring a massive, violent spike in pressure that would cause barotrauma.
That makes perfect sense. And what about our oxygen targets? When you are standing in the ICU at 3 a.m. and the oxygen saturation is dropping, your instinct is to turn the dials up to fix the numbers.
You have to fight that instinct. We accept a lower target oxygen saturation, usually around 92%.
And for CO2?
Crucially, we utilize permissive hypercapnia and respiratory acidosis. We intentionally allow the carbon dioxide levels in the blood to rise higher than normal and the blood to become slightly acidic.
Just to protect the lungs.
Yes, attempting to force enough air into those stiff lungs just to blow off that CO2 would cause unacceptable catastrophic barotrauma. It feels wrong to let the numbers look bad, but it is exactly what protects the lung architecture.
It is a delicate balancing act. But what if that conventional lung protective ventilation completely fails? The patient is still hypoxic and the pressures are still too high. What is our recognized rescue strategy?
When conventional ventilation fails, the rescue strategy is high-frequency oscillatory ventilation, or HFOV, which uses tiny, incredibly fast pulses of air to facilitate gas exchange without stretching the lung.
Briefly, before we wrap up, what are the long-term complications? The patient survives the fire, they survive the ICU stay. What legacy does this persistent inflammation and long-term intubation leave them with?
Well, the structural complications of long-term intubation are tracheomalacia, a severe weakness and floppiness of the tracheal cartilage and tracheal stenosis.
And from the smoke itself.
As for the inhalation injury itself, the medium-term result is ARDS and multiple organ dysfunction syndrome, or MODS. In the long term, the chronic inflammation causes permanent architectural changes, specifically extensive fibrosis, which eventually leads to emphysema and bronchiectasis.
We have covered incredible ground today. Diagnosis traps, airway anatomy, cellular poisons, and ventilator mechanics. But I want to leave you with one final specific scenario to mull over before exam day.
Let's hear it.
Let's say you have managed the airway perfectly. You diagnosed the carbon monoxide poisoning early. You treated it with 100% oxygen. You did the half-life math. And the carboxyhemoglobin levels on the blood gas have dropped back to baseline.
Everything looks good on paper.
Right. But when you look at the patient's labs, they still have a persistent, profound metabolic acidosis that absolutely refuses to clear.
This raises an incredibly important question. If the carbon monoxide is gone, but the cells are still starved of oxygen and still producing acid, what is happening?
Exactly.
That persistent metabolic acidosis is a massive red flag. It means you must immediately suspect concurrent poisoning by another deadly combustion product, cyanide.
Cyanide poisoning. It is the hidden second killer in the smoke. Think about that interplay the next time you look at a blood gas from a burn victim.
It's a crucial differential to keep in mind.
It really is. That brings us to the end of this deep dive. To everyone listening, if there is a specific piece of pathophysiology, a ventilator setting, or a clinical mechanism from today's session that you want clarified before exam day, drop a comment or a question below. We are here to help you nail these concepts. Keep grinding, keep reviewing, and we will see you on the next one.